Good afternoon, everybody. Thank you, Dr. Nitin, for inviting me on this webinar today. So today's topic, which is given to me, is administration and scoring of CARS in clinical practice. Although it is quite difficult to cover it 1 hour, but I'll try to cover it, and we'll be focusing on basically the overall aspects and how the scoring is done. And probably after going through today's webinar, we might be able to get an idea on how the scoring is done and how it is different from probably from the other scores. So without wasting time, I'll start with the presentation. I'll just make it full screen. Yeah. So first of all, a brief general description about the CARS. So the Childhood Autistic Rating Scale includes the 3 basic things: the rating booklet, which includes the scoring system, the scale, and now it has been revised with this CARS 2, that is Childhood Autistic Rating Scale 2 Standard Division. So this is the standard rating scale which has now been revised. Formerly it was called as CARS. Then another thing which has been included in is, along with the CARS, they have included the CARS HF, that is the CARS scoring which can be done for the high functioning, which are mild or which are coming under the PDDS or which are coming under Asperger. The third is the questionnaire for the parents and the caregivers, because it's more or less a parent or teacher questionnaire based scoring, plus the direct observation by the clinician or the person who is doing the scoring. So and these 2 scores. So now I'll be mainly focusing on the CARS 2. That is not, I will not be focusing on the HF. We'll be mainly focusing on the CARS. Sorry? Dr. Nitin, you were telling something?
Sir, the slides are not visible.
Slides are not visible?
Small, you need to and make the slide.
Just a minute. Is it okay now?
It's okay.
Okay. Yeah. So the CARS score, so the CARS score is not intended for the purpose of screening, like we do other scorings like MCHAT. So they are not for the purpose of screening purpose. They are for the purpose of diagnosis. And depending upon their value and depending upon their values, what they come, they have been categorized into mild, moderate, or severe. And the good thing about this CARS 2 ST compared to the previous CARS is that it directly correlates with our DSM-4 criteria, which comes into the different levels of functionality of autism, whether it is partially dependent or it is requires substantial support, or a child requires very substantial support, which has been classified into 3 different functional categories of autism. So this scoring of CARS more or less correlates with the functionality of the severity of autism. So that we'll be seeing in our coming slides. So the Childhood Autistic Rating Scale has been used since 1970s, and it was being developed by Skopla and these persons. So the second edition of CARS has now added further things, which I am telling you that along with the CARS, now we have coming with high functioning. So there is a difference between the 2, that is the CARS 2, the second division, and CARS HF, that is high functioning. So they have been added, and as I've told you, this high functioning category of CARS scoring is used for those who are coming under Asperger, who are coming under high functioning, and those who are not coming under the severity of autism spectrum disorder. Now, this CARS is a product of WPS, that is Western Psychological Services. And if anyone interested, one can purchase it from there also. So this CARS, whether we go for the CARS or we go for the HF, They include 15 items that are responsive that an individual has to be rated on the basis of them. And those 15 items are rating on a scale of 1 to 4, and in those key areas which are related to the autism spectrum disorder. So those 15 items which are there in the booklet or in the questionnaire, on which the scoring has to be done by the clinician or the person who is doing the scoring, he has to rate those 15 items on a scale of 1 to 4, depending upon the observation, that is the direct observation, and depending upon what the parents or the caregiver gives during the questionnaire session. So a list of ratings are included in this form. And then depending upon that, you have to categorize them, whether it is a mild, whether it is mildly abnormal, whether it is moderately abnormal, or it is very severe. So the ratings are then those values which come. You are giving a score of 1 to 4 on those three different 15 items, and those raw scores are then calculated together to form the total raw score. Now that total raw score, when it comes, then depending upon that total raw score, the child will be characterized as mild to moderate, moderate to severe, or no autism symptoms. So the broad difference between the two scores, that is the CARS 2, that is second division, and the CARS 2 second division high functioning. So these are the 15 categories, or I would say these are the 15 items on which the scoring is done. So, and on these 15 items, we are rating the scores from 1 to 4 on a scale of 1 to 4. Now, I'll be focusing today mainly on the CARS 2 second division. I will not be focusing on HF, but just to give you a clarity, what is the difference between the two? The CARS 2, that is a standard one, it is rating is done for individuals who are under 6 or those who are above 6 with an estimated overall IQ of 79 or lower. Whereas HF is done for referred individuals aged 6 and above with an estimated overall IQ of 80 or higher. And if you go through these 15 parameters, there will be a slight difference between the two. If we go for the relate to the item 1 in standard division, it is coming for the item number 1 is relating to people, whereas in HF it is coming social emotional understanding. So this is how there is a difference between them, but all the items here also there are 15 items, here also there are 15 items. So if I mainly focus on the CARS 2 standard version, leaving aside the HF, we'll be now discussing on these 15 parameters, that is the relating to people, imitation, emotional response, and so on. So what are the advantages of these CARS 2? So it covers the entire autism spectrum. As I have told you, it correlates with the DSM-4 functional criteria of autism, depending upon little substantial support, very substantial support, and extreme substantial support. That is category 1, 2, and 3. Another thing is that it is based on decades of use with thousands of referral individuals. So it is a standardized scale which has been used. It assesses the virtually all ages and functional levels. It correlates directly with the DSM-5. Earlier in DSM-4, there was no such functionality, classification or categorization of autism spectrum disorder. So it provides you a concise, objective, and quantifiable ratings based on the behavioral observation. So scores show a consistent, strong, and positive and specific relationship with autism diagnosis. So they are very reliable, and they have been studied over a period of time with lot of these scales have been studied over a period of time and over a lot of diagnosed individuals. So means to say the sensitivity, the specificity compared to other scales is very, very high for CARS. But it is not considered to be the gold standard. The gold standard for autism rating is nowadays considered to be either ADOS, but ADOS is very, generally we are not doing ADOS because it takes a lot of time. So that is the reason. Now, what are the another advantages? Scores. Now the cutoff scores, the standard scores, and the percentiles. So the thing is, when you are giving the rating of CARS, it can be done. Standard scores are also given. That means standard deviation can also be calculated. Percentiles can also be calculated. There are another thing which is known as T scores. We'll be discussing in our coming slides. And there are cutoff scores to categorize the category of autism: mild, moderate, severe. So the format is, it is contained basically 15 item rating scales, which I have told you, and the scoring is done on the scale of 1 to 4. Now, one important thing is, for a person or for the person who is doing this scoring, if he's very much well versed and has done over more than 30 scoring on the autism spectrum disorder with different levels of children on autism, then even then taking a score even at one single setting is enough. But if a person is new and he has not been well versed with the scoring of autism on a majority of children, then an average of 2 is taken. The reason is probably if a child is traveling from a very long place, he might be not be comfortable, he might be tired, he might not be well fed, or he might be showing lot of behaviors in a new setting, which probably he might not show when he's more comfortable or probably well fed. So all those things taken into consideration, that has to be taken when you are doing the scoring. Probably the child might show an extreme behavior in a single sitting when the scoring is be done. And probably when he's well fed and he's in his own environment, comfortable environment, the scoring might automatically change. So that is why it is said an average of 2 is always need to be taken. And the prerequisites is it should be in a comfortable environment. Child should be well fed. He should not be suffering from any medical issues in the sense fever, throat, and etc. and etc. So all those things need to be taken into consideration when we are doing a CAR scoring for the first time on the child. So administration time is generally 15 to 20 minutes as they tell, but generally if we are doing for the first time, it will definitely take an hour to 45 minutes. But when you, as I've told you, when you have done repeated practice over the children, then probably it might take hardly 15 to 20 minutes. Age is 2 years and up. So this is the peculiarity of this cards, that you can do the card scoring over a wide variety of ages. So these are the cards, these are the various 15 items which are addressing the functional areas. So relating to people, imitations, emotional response, body use, object use, adaptation to change, visual response, listening response, taste, smell, fear, verbal, non-verbal communication, activity level, level of consistency, and intellectual response, general impression. So you can say that these 15 parameters which are included in these cards, they basically cover the overall phenotypical presentation of a child on the spectrum, irrespective whether it is mild, moderate, or severe. So it is taking into consideration the sensory issues, it is taking into consideration the behavioral issues, it is taking into consideration the stereotypic movements, it is taking into consideration the relation in contact to the children, their eye contact, the response to name call, and another thing, even the tactile sensory issues. So that is why this new edition, that is the second edition of cars, directly correlates with the functionality of DSM-4. Because in DSM-5, sorry, in the previous criteria DSM-4, they were not including the stereotypic movement. The sensory issues were not included. But now in the latest DSM-5 criteria, they are now including the sensory issues. So that is why, because of this involvement of sensory issues, CARS 2, the second edition, correlates very well with the latest DSM criteria, functional criteria for autism. So rating values for each cards is range from 1 to 4, as I've told you. Now, another thing, now what does this rating means, 1 to 4? So a rating generally one indicate that an individual behavior is within the normal limit for that particular age. So we will be comparing it with that particular age compared to a neurotypical child. So a value of 2 means that individual behavior is mildly abnormal with a person of the same age. So value of 3 means individual's behavior is moderately abnormal compared to that age. So just we have to remember 1 is normal, 2 is mildly abnormal, 3 is moderately abnormal, and 4 is severely abnormal compared to that age. Now there is some another scoring is done in between the two. Suppose a child which comes where he doesn't fit into the score of 2, and he even doesn't fit into the score of 3. For example, it might be mildly abnormal and it might be little more than mildly abnormal, but it not be severely moderately abnormal. So in that case, we use a category of what is known as 2.5. So a score of 1.5, 2.5, and 3.5 have been also included in this scoring of 1 to 4. So for example, a score of 2.5 would be mildly to moderately abnormal. So he is not exactly moderately abnormal and he's little beyond mildly abnormal. So that is why it is not fitting into 2 and 3. So it is fitting somewhere between 2 and 3, between 2 and 3. So that is called 2.5. So mildly to moderately abnormal. So if we consider these, a total scoring would be 7 scores, 1 to 4, and 0.5 scores, 1.5, 2.5, and 3.5. So thus a 7 allowable ratings are there when we do a scoring. So these 7 ratings are: 1 means with the normal limits, 1.5 means very mildly abnormal for that age, 2 mildly abnormal, 2.5 mildly to moderately abnormal for that age, 3 means moderately abnormal, 3.5 again moderately severely abnormal, 4 is severely abnormal. So this is the 7 scorings which can be done on all these 15 parameters. So remember, so these are the most important things which have to be taken into consideration while doing the scoring. So scoring actually is not tough. It's once we start working on the child, we will be well versed with the scoring generally after maybe 5 to 10 or maybe 15. But the important thing which needs to be taken into consideration is what things need to be taken while doing the scoring. So remember that in determining the degree of abnormality, one must take into consideration the most important age is the chronological age of the child. Along with the chronological age, you need to take into consideration the developmental age plus the behaviors what he is showing. That is what we call the direct observation which we are doing during the assessment. So the four important things which need to be taken into consideration is frequency, frequency, intensity, and the duration of his or her behavior during your observational period of 15 to 20 minutes or maybe 40 minutes, depending upon how much time the one individual is taking while doing the scoring. So peculiarity means the extent to which a behavior is unusual or odd in general as to whether it is delayed or like the behavior of a younger child. So peculiarity means what type of behavior and extent to which typical that unusual behavior is showing. So that unusual behavior might be he is doing a lot of stimming, he is doing a lot of side cornering, he is flapping hands. So those things need to be consideration what typical peculiar behavior is doing. So frequency means how frequent it is happening. Suppose in a observational period of 20 minutes, he is doing stimming every 2 minutes, every 3 minutes. So that will tell you what is the frequency, what is the severity of those behaviors is doing. Duration, how long that behaviors last. So while observing those behavior, you need to take the total consideration of the behavior. For example, he's doing stimming for every 2 minutes, he's stimming for 5 seconds. He's stimming for 5 seconds, or he's doing hand clapping. So you need to calculate the total duration of all the episodes, not a single episode. So these things need to be taken into consideration while doing the scoring. And intensity, how severe those things are happening and how severe they are, whether he's doing very or he's very much lost in his own world, he's aloof to a very large extent. For example, if the examiner is calling him, Amit, come here, he's not responding. Amit, come here, he's not responding. So depending upon how much time he has to call the name, the child, that will set us give an example of an idea that how severe the child is aloof. So those things need to be taken into consideration while observing the child in the direct observational period. So what I decided that I will discuss on this rating of cars on the basis of an example. I have taken a case example. So this is a case of a Mitchell who is a 4-year-old child, and he has come to us at the clinic for the purpose of scoring. So we'll be doing the car scoring on him on the basis of direct observation. So as I've told you, the scoring needs to be done on the direct observation by the clinician or the person who is doing the scoring. And second, on the basis of direct interaction with the parents or the caregivers who are coming along with the child during that period. So item one, as I've told you, so I'll be now discussing each of those 15 items. So item one is relating to people. So relating to people means you need to take into consideration as soon as the child enters into the examination room, how does he react? How does he react towards the stranger? Because me as an examiner, if I'm examining him, I'm a stranger to him. So how is his reaction towards the stranger? How he reacts to the peon who is sitting outside? How does he reacts to the parents when a child enters into the examination room? Is he comfortable? Is the mother requires a lot of attempts to tell him, say, greet the uncle, say hello. So all those things need to be taken into consideration. And when the doctor comes to him, he shakes hello. How does he feel that contact of that person? Is he resist? Is he want to come towards him? Is he want to hug him? Depending upon tactile issues they might be. So those things needs to taken into consideration while you are observing his behavior towards relation to the people. So what considerations needs to be taken is reacts to behavior ranging from persistent or intensive attempts at making the child response. Then how persistent or forceful an adult must be to get the child attention. As I was telling you, suppose a child enters, hello, how are you? How are you? So I need to tell him repeatedly again and again in order to gain his attention. So that means his relation to the people is not get connected. So those things need to be taken into consideration. Second, as I've told you, how about his physical contact? Because when I'm examining him, I may need to shake his hand. I may need to develop his repo with him before doing an examination. So while developing an repo, I may hug him. I maybe a physical contact maybe with him. So does he resist that? Does he like affection or does he resist that? So those things need to be taken into consideration. Other things, aloof, shyness, and awareness. Is he well connected with the environment? Does he know that I have come to a place which is, which is to which I'm not very much aware of? Or he's totally aloof. He doesn't know whether it is a home, it is a place, or what is it. So those things need to be taken. What we call as social awareness, that is awareness of his surroundings. So suppose in this example, the observation, so this is the scoring card. I have taken a small examples of each of these. This is how the scoring card will appear. So relation to the people. So this is the scoring, the circles which have been meant, that is the scoring which has been done by the clinician or the person who's doing the scoring. So in case of Mitchell, what are the observations which has been made? The observation which has made by the observer is he ignored his name when he's being called, doesn't always respond to attempts to engage, like peekaboo, rolling, throwing a ball, initiated to get a snack video, not to play or show something he's done. So responded to others, that is when he was being asked, he responded to others. So social approach, or I would say social awareness was there. So hard for him to sustain a reciprocal interaction or initiate interaction. So he responded well, in the sense he was trying to respond to the social approach, but the problem was he was not able to continue that interaction. That means reciprocal interaction was not there, and he was finding it difficult to initiate interaction. I had to tell him repeatedly again and again, give him some reinforcers to initiate his interaction, but he was not able to interact by his own. So depending upon this scoring, the child fits into the category of 2.5. I'm sorry, I'll be going little fast because although it takes a lot of time, it takes at least 2 to 3 hours when we discuss on this. But since there is a time limit of 1 to 1 point, maybe 45 minutes, so we'll try to rush it a little fast. So depending upon this, the scoring would be 3. Why the scoring would be 3? Because these features, what has been observed by the examiner, comes into the category of moderately abnormal relationship. So what does this moderately abnormal relationship says? The child shows aloof, seems unaware of adult. Persistent and forceful attempts are necessary to get the child's attention at times. Yes, exactly. In this case, the observation has been made that the child was requiring persistent efforts. That means we need to give him persistent reinforcers in order to gain his attention. Although he was started initiating by his own, but he was not able to maintain that reciprocal initiation. So those things clearly indicate that the child is coming under the category of moderately abnormal relationship. So relating to people, the score of 3 is given to this child. So minimal contact is initiated by the child. Exactly. So minimal contact, there was no initiation. We had to give him, repeatedly stimulus in order to initiate. So that is why, depending upon this, the scoring comes for 3 in relation to people. So coming to the next item is imitations. So in imitation, what things need to be consideration? You need to look into the verbal imitations. You need to look into the non-verbal imitations. So non-verbal imitations means, how does the child copy? What about is when we are clapping, is he clapping? When we are touching our ears, is he doing? So what we call as action imitations. So probably a child, maybe a 4-year-old child who is a non-verbal child. So you cannot ask him to copy verbal imitations. Then you need to check his, what about his action imitations? Is he clapping? Is he clapping? Is he raising his hand? Is he touching his eyes? So in those cases, you don't have to give him, okay, touch my ears. You just have to stand in front of him and do these actions. And the caregiver will tell him, okay, so and so you have to now copy his uncle's imitations. So probably when he is clapping, he might also clap. When you are raising your hands, he might do it. When you are doing whatever actions, when you are doing funny faces, he might do that. So those are known as action imitations. So in a non-verbal child, does he doing those action imitations or not? If he's a verbal child, then you need to see what verbal imitations he can do it or not. Can he sing a song or maybe a rhyme or maybe a peekaboo, whatever, one word or two word? Does he doing wave, bye bye? So those things need to be taken into consideration. Then copying skills regarding, does he able to copy the shapes with pencil players, or is he able to cut the scissors? Now important thing is, while doing these observations, you also need to observe, as I was telling you, the developmental age and the chronicle age of the child. A 2-year-old, for example, a 3-year-old child with poor gross and fine motor skills may not be able to cut the scissors, may not be able to cut the pencil with this, may not be able to cut the shapes with the scissors. He might require moderate and substantial support in order to hold his wrist, because that fine motor skills may not be there because of the poor tonicity of the muscles. So as a result of this, it doesn't mean that he's not doing imitations. You need to look into other factors of verbal imitations or maybe action imitations, like clapping a hand, raising those things, as I've told you. So try to note a wide variety of situations where the child is being asked to imitate. So as I've told you, you don't have to stick to a one particular thing. Imitations need to be done over a wide range of sequences, over a wide range of situations. And depending upon that, you need to figure out what is his level of imitation for the child in that particular scenario. So in this case, the examination finding was not watching others. So he was not watching others, could get attention and demonstrate things for him to do. Sometimes try to do what was shown to him. So sometimes try to do what was shown to him. That means he was doing imitations, but only for 50% of times. Didn't hold a kaleidoscope to his eyes to look through, did imitate, evaluate rolling Play-Doh. So he was trying to play with a Play-Doh, but he was not, he was trying to play, he was trying to imitate, but not exactly, he might not be able to draw, draw a car or a ship, but he was trying to imitate something with a Play-Doh. So that means imitations were there, but again, the child initiates only a part of the time and requires a great deal of persistent help from the adult, frequently imitates only after a delay. So that means again he comes under the criteria of 3. Now these scoring which is done, it is totally a subjective scoring. So for me, a scoring might be a different for this child, and for you, when you do a scoring, it might be a different for that for the same child. So that is why it comes with a practice and practice. So there always can be two school of thoughts. For me, it can be a score of 2.5. For you, it can be a score of 3. So the take-home message is the scoring and practices will come gradually as we keep on doing scoring on a more and more number of children. So for this child, the scoring will be 3 because he does imitation in 50% of the cases, but those imitations are with a delay and he requires strong, substantial motive and support and encouragement to do that. So that is why the score comes out to be 3. Why it is not 2? Because the child imitates simple behaviors such as clapping, single verbal sound most of the time, occasionally imitates only after podding or after a delay. So the score is not 2 because he is not able to imitate simple behaviors such as clapping, simple verb sound ma, pa, ta, na. He's not able to imitate those things, but he's able to imitate some action imitations. Probably the child might be non-verbal. So we don't know. So as a result of this, the score for this child comes into the category of 3. That is moderately abnormal. So when we come for the emotional response, so emotional response, what things you need to look into the consideration is how about his behavior for the child. A child of the same age is sitting here and he is being hurt. Does he laugh by seeing him? Does he feel hurt? Oh, he has been hurt. I should go and try to hug him. I try to give him first aid. Or in our case, he was a 3-year-old child, Mitchell. So a newborn baby or maybe a small kid who is younger to him, 1 or 2 years younger to him, when he's hurt, does he go and help him? So those things need to be taken into consideration. If mama scolds him, not by physical abuse, not by slapping, but just the facial expression. Is he able to read those is he able to read those facial expressions of the mother that yes, she is angry or she wants that she's scolding me? So those things need to be taken into consideration. If a child falls down and he gets he gets an abrasion on his skin and there is a bleeding comes, so how is his reaction? Is he feels very comfortable? He's not, he's continuing playing and he's not bothered about that cut. And there may be, so in this case, the child is undersensitive. So there may be a child where there is a little abrasion has been cut, just a mark. There is no bleeding, nothing. And he's shouting like anything, he's screaming like anything. So in that case, probably he is hyposensitive. Sorry, he is hypersensitive. That means the response to that painful stimuli is much, much higher than the major normal percentage of the population in this age category. So those things are always need to look into consideration while doing these observations on emotional response. So emotional response in this age category. So what were the observations which the child was noted in this score is, so narrow range of emotions, showed pleasure during the activities of highest interest to him, smiled. Overall, he had little overall change in facial expressions. So once during assessment, he became quite upset, crying, reason was unclear. So one important observation which was noted by the examiner is that during the assessment, the child was sitting comfortably, but without any reason, he suddenly started crying. Just give me a second, please. Yeah. So he started crying. So the reason for that crying was not clear. So when we look into the scoring for this child, it comes out to be 2. So if we look at the scoring of 2, what does it say? It says that mildly abnormal emotional response. The child occasionally displays a somewhat inappropriate type or degree of emotional response. Reactions are sometimes unrelated to the objects or events surrounding him or her. So reactions are sometimes unrelated to the objects or events surrounding her. So as he has noted that he was comfortable in the examination room and suddenly he started crying. So why that emotional burst out came, we don't know. So the reason was unclear, and that exactly is mentioning here in scoring of 2, that reactions are sometimes unrelated to the objects or the events which are happening. And the child occasionally displays somewhat inappropriate type or degree of emotional reaction. So the child is responding to the emotional reactions, though his range of reactions or emotions are limited, very narrow, but yes, he's showing interest, he feels happy, he smiles, he has an interest towards that particular toy, so he gives a smile, he's happy. But on the same side, his facial expressions are not to that extent, and there is an emotional outburst which happened in this child without any unreason related to that situation. So that is why the score of 2 is given. So if we go to the score of 3, you see the child shows definite signs of inappropriate type or degree of emotional response. Reaction may be quite inhibited or excessive and related to the situation. Child may grimace, laugh, or become rigid, and even no apparent emotional producing objects or events are present. So you can see in category 3, the severity is much, much higher. And where the observations which have been found in this child are not related to that much severity. So that is why a score of 2 has been given. So when we come to the body use, so in body use, what things need to be look into the consideration? What is the posture? What is the tone of the body when you are doing things? For example, when I'm writing, some kids on the autism spectrum disorder, because of the poor tonicity, or because because you can say low tone, they might be writing very low. They might be doing head down and writing. Or when they are doing cycling, they might not be able to forward pedaling. They might be doing backward pedaling. They might be very much clumsy in taking a glass of water from the kitchen to the room. They might be very much clumsy while walking the staircase or coming up and down. They might be able to come up but while going down the staircase, they will not be taking one step at a time. They will be taking 2 steps on one staircase. So those things need to be consideration, the tone, the posture, are they swaying towards one body? So those things need to be taken into consideration. So consider the activities like scissors, drawing, puzzles making, physical activities, cycling. So these I have just given an example. Body use can be done over a wide range of things, as I have told you. So your imagination, your thought is not limited only to these context of these things. So body use can be, you can take into consideration depending upon the variety of items which the child does or he can do depending upon that particular age and his developmental requirements. So for the body use, if we say, as I have told you, clumsy. So the child was clumsy. Probably the observer has noted that the child is very much clumsy. He's not very much, his body tone doesn't give a good impression to the child. So he might be taking a pencil or might be taking, a water bottle from the table and might be from the mother to and keeping it on the table. The observer might have observed that duration of taking the bottle from the mother and keeping it on the table. He might be very clumsy. He might not be able to hold it properly as a child of that particular age. So those things need to be taken into consideration while observing the child. So clumsy, but no unusual body movements, no rocking and spinning. So body use, another important thing which need to be looked into consideration is, does he doing head rocking? Does he doing stimming? Does he doing head banging? So those things come under the body use. Is he doing visual, I mean the corner side seeing? So those things, is he doing flapping, hand flapping? Is he doing, is he staring at the fans? Is he staring at the bulbs? Is he taking a lot of visual stimming? Is he laughing by seeing bright lights? So those things need to be taken into consideration for the body use. So in this category, there was no unusual body movement, no rocking, spinning, but yes, there was a clumsiness was there in the child. So that means the child was mildly abnormal, but he has given a scoring of 1.5. So why the score of 1.5 was given? Because he is not normal, but he is little above, I would say little better than mildly abnormal. So in mildly abnormal, what is the description is, some minor peculiarities may be present, such as clumsiness, repetitive movements, poor coordination, or rare appearance of more unusual movements. So in category 2, score of 2, we have clearly mentioned that along with clumsiness, there will be repetitive movements. That means repetitive stereotypic movements of stimming will be there. Whereas in the observational finding by the clinician, he has clearly mentioned there is no rocking and spinning. So that clearly fits that the child is not into the category of 2, but it is somewhere little better than category 2. So it comes out to be 1.5. So object use, again, when we going for the object use, we have to look into the consideration how the child plays with the object. For example, does he play only with the wheel of the cars? Does he play only with the wheels, or is it does he know the functionality of this car? Pass and throw, does he know? Is he playing with the ball? Is he know, does he know the concept of throwing and take away, passing and throw of the ball? Or is just visualizing the ball in a form of circle and laughing and observing the different colors and bright colors of the ball? So those things need to be taken into consideration. Is he lining up the toys? Is he playing with the blocks and making them proper blocks and making something? Is he stacking those rings, or is just lining up, what we call as a stimming? So those things need to be taken into consideration. Then was some children, while going into the toilet, they may continue flushing and reflushing, because they might take a lot of visual stimming from that, the rush of water which is coming. So those things need to be looked into consideration. Is he enjoys very happy in tapping on and off of the taps in the wash basin? So that might also be an indicator of taking a lot of visual stimming. So those things need to be taken into consideration. When the book is being given to them, is he keeps on flipping the books continuously, or he observes the pictures, or is he observing one particular picture at a time again and again, or is he flipping it continuously? So those things need to be taken. So as I have told you, uh, the observations can be done over a wide variety of things, wide variety of range, but these things, considerations need to be taken before doing a scoring on that particular item. This is very, very important. We need to keep ourselves very clear, and our thought should be very clear that on what basic things we need to do a scoring on this particular item for this particular child. The reason why I'm telling you, because once we label a child on autism spectrum disorder, it becomes very, very difficult for the parents to accept. Acceptance doesn't come very, very easily. So it takes a lot of time to make them, understand that what your child is going through and what are the issues with your child. And I think I had also shared recently, I had prepared a book, handbook on autism spectrum. So that can be a very, useful visual tool for the clinicians and for us to show to the parents, so that they can get a better idea that is your child using a proper use of those things. He might, instead of using a toy, he might line up. So we can show that visual picture, that is your child doing like this, or is he playing like this with compared to a normal then probably by visualizing this they might get a better idea. Yes, probably something is there wrong in my child which is not going the right track. So those things are very, very important when we are doing the scoring, because acceptance also is very, very important for them uh, to know that yes, something is wrong in my child. So for this particular child, for the object use, there was not much interest in the toys in the play area. So that means there was no interest, there was no proper use of the objects. He doesn't know, and there was not at all interest with playing with the toys. No exploration during the free play time. Evaluator showed him a small toy of a cartoon character, played with it in a repetitive way. So you can clearly see that here the child behaviors of with the object use were little much higher. They were probably moderately higher, because there was no enthusiasm of the child with the toys. He did not know how to play with. He was just rotating it continuously in a repetitive fashion. That means stereotypic movements, probably with the wheel or anything. He was not knowing the functionality how to play with that particular toy. So as a result, the score of 3.5 is given. So why not the score of 3 is not given? Probably here the score, his behaviors were little more higher than 3, but they were little less than the maximum severity of that particular thing. So what does the score 3 says? The child may show little interest in toys or other objects, but here the child, he is mentioning the child might show little interest, but here the child was not showing any interest at all. So that is probably the reason. And plus, in this category 3, they have also mentioned the child might show some type of repetitive behavior, but here the child was continuously playing in the repetitive fashion. So that's why the score of 3.5 is given. But that severity might not be to that extent that he might be given a score of 4. So item 6, adaptation to change. You know that children on spectrum, they are very, very stubborn. A black shoe has to be kept on shelf 1, it has to be on shelf 1. You cannot keep it on shelf too. My shoes come first, your shoes come next. It has to be in same way. It cannot be vice versa. I'm going from this part to my school. It has to be from this path, no matter whether the road is blocked, whether the construction is going on, he will start showing tantrums. I'm sleeping at 9 p.m. in the night. I cannot sleep at 9:30. I will throw tantrums. I will throw meltdowns. I'm comfortable in sleeping on my bed at 10 p.m. in red bed sheet in a temperature of 25 degrees Celsius. I cannot sleep in a wedding hall where the marriage is going. I cannot attend all this. So these are the changes which we typically see in a child who are difficult to find adaptation to the change. So I just given you very, very simple examples. It can be endless number of examples you can take into consideration. Another thing is he very stubborn about a particular type of texture of food he wants to change? I'm eating this, so I want to eat this. I cannot eat. Is he playing with a car continuously? And suppose you tell, okay, now it's your time to read. Just forget about this car. Let's go and play with this car. So is he able to adapt to that change, or he starts showing uh, resistance? What type of resistance? To what extent the resistance is there? Do you require a lot of effort to make him change from one situation to another? It might take 4 hours, it might take 5 hours, and finally at the end of the day the parents might not be able to make a change in his adaptation. So depending upon the consideration of these changes, what particular severity of adaptation to the change the child requires, you need to look into consideration, and depending upon that a scoring has to be given. So now let's see, in this child, he actively resisted changes in materials, winning resisted placing finished materials off table. So he was actively resisted to changes in materials. So he was not comfortable and he was resisting changes. Placing a new material on table to switch his interest, easier to take away other items. But similarly, in one situation, he was able to shift to a new item, and the mother was able to replace another item from him. So that means in one particular situation, he was resisting, but in another particular situation, he was able to adapt to the change. So a score of 2.5 is given. Why? Because in moderately abnormal, they say that the child actively resists changes in routine. He tries to continue the old activity every time. Whereas in this case, the child resisted to one particular situation, whereas in another particular situation, he was able to adapt to the change. So that is why a score of 2.5 is given, because he doesn't fit into moderately abnormal, but he neither fits into mildly abnormal. So that is why a score of 2.5 has been given to this child. Now, then you have the visual response. So in visual response, what things we need to look into consideration is, consider whether the child uses his or her eyes normally. That means the things which you need to, is he looking side corners? Does he give you an eye contact? How about his response when some stranger comes, he greets? Is he able to look into the eyes? Is he ignoring them? He gets a lot of anxiety. He tries to avoid the situation. We don't want to give an eye contact. He starts looking here and there. So those things need to be looked into consideration. Then another thing is visual stimming. Is he enjoying a lot of flushing of waters while seeing? So those things need to be consideration while doing an object use. So while doing, for example, when he's flushing the tap on and off again and again, you are making the scoring on the use of object use, plus you are making a scoring on the visual response, because he object use is tapping on and off. So you can make it out that he doesn't know the proper functionality of that object use. Second thing, you are also making a response on his visual response. He's taking a lot of visual stemming from the running tap water which is coming, and he's getting excited. So those scoring, so from that pattern of behavior, a scoring on two things can be done. So that is, I have told you that it can be a variety of situations, but the only thing we need to take into consideration, and our mind should be clear that yes, we need to observe on these parameters when we are doing a scoring on these particular situations. So when it comes to visual response, eye contact is inconsistent, often not directed to the evaluator. So there is no eye contact, it is inconsistent, distracted by looking at self in mirror during the play with the ball, looked at things very closely, often looked from the corners of the eyes. So again, depending upon these scoring, this eye contact was not good. He was distracted as self in mirror during the play with the ball and looked at things very closely, often from the corners of the eye. So that means here again, they have mentioned a score of 3. So in a score of 3, they have mentioned that the child must be reminded frequently, look at what she is doing. So as a result, I've told you, The examiner need to distract him again and again so that it doesn't get obsessed by observing his image in the mirror. So the child will remind, so we need to remind the child again and again. He or she is staring into the space, avoid looking people in the eyes, look at objects from unusual angle or hold objects very close to the eyes. So again, in this category, it could be three, it could be three. Sorry, they have given score. Yes, they have given a score of 3 only in this case. So why they have given again that he was looking with to the objects with a very close observation. That means bringing to very close to the eye. He was looking from the corners of the eye. So all those things which are there in a score of 3, all more or less the things are there in this child when the examiner has observed those child. So the observations which has been noted by the examiner are matching exactly in the score of 3 for this child. Then we come to the listening response. Again, in listening response, what you need to look into consideration is basically in this thing, you mainly look into the consideration is auditory processing issues. Like, does the child enjoys very loud music? To one side, he might not enjoy a loud music at all. To other side, he might hear just a whispering of a noise from the from a neighbor's room, or he might be totally uncomfortable through the normal music which we are comfortable, like a noise of a television, noise of a music, but he might not be comfortable at all. He might be not be comfortable at all to two persons talking in home. He might get irritated. He might be uncomfortable to the normal sounds which we usually hear in our day-to-day routine life, like the noise of pressure cooker, washing machines, ACs, horns, so those things. So those things need to be look into consideration when we are observing the listening response and listening skills of the child. So again, in this category, we see what were the observations. No immediate response when his name was called. So there was no immediate response. So that means there was no response to call name, which is a very, very important hallmark when we look for early signs of autism or red flag signs. No response to call name. So no immediate response when his name was called. Did not turn to face person calling. So it did not turn when a response was given to him. So no turning of head towards the person when the name was called. Often had to be called several times before responding. So we need to give a continuous and repeated stimulus for the child in order to gain his attention. Sometimes no response to unexpected noises, and at other times appears startled by them. So that means his response to the noises was very, very unexplained, or it was totally, dramatic. To some extent, in one particular situation, he was responding well, and to other particular situation, he was not at all responding, and he was showing totally unexpected behavior. So in this category, they have given a score of 2. So mildly abnormal listening response. So what does this mildly abnormal listening response says? They say that there may be some lack of response or mild overreaction to certain sounds. Responses to sounds may be delayed, and sounds may need repetition to catch the child's attention. The child may be distracted by extraneous sounds. So if we go to the score of 3, what does it say? It says that the child responses to sounds vary, often ignores a sound the first few times it is made, maybe started or covers ears when hearing some everyday sounds. Now, one thing is very clear is that in score of 3, the child will be covering his ears when there is an unusual sound or being loud sounds being heard. Probably this thing was not here in this child and there was no observation. And also, along with your direct observation during your scoring, you need to ask with the parents that whenever you go out to a mall, whenever you go out to in a situation, wedding party, how is his reaction? The mother might say he's not comfortable. He might go away from that situation. Yeah, and when he comes out from the hall party hall, he feels comfortable. But here the mother never mentioned that when he enters the hall, he closes his ears. So that those things are very, 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 very important. Each and every point which is mentioned in this score is very, very important. So that is why in point 3, it clearly mentioned he covers his ears when an unusual noise sound is heard. So in wherever in the patient history, in the direct observation by the clinician, there is no such observation being made. So you cannot go give a score of 3 to this child. But at one particular time, you would observe a score of 2 doesn't fit into this child. He is little more than that, might be 3. But in 3, when you read it, it clearly mentions that he covers his eyes and those things. So those things are not being mentioned and neither by the parents. So we cannot give a score of 3 in this. So as a result, a score of 2 is given because majority of the symptoms fit into this criteria. Then you have taste, smell, touch, response, and use. So consider whether the child shows either excessive avoidance or excessive interest in certain foods, order, taste, or textures. So taste, smell, touch means you need to look into consideration means what about his habit? Does he have lot of mouthing issues? Does he take lot of inedible things in the mouth? Does he smell each and every item while taking in the mouth before tasting on keeping it on the tongue? How about his response? Does he have a lot of tactile issue? Does he have the habit of touching each and everything when he's going out in a market? Does he feel touching each and every person in the room or maybe in the school? But another important thing, when you're observing these mouthing behaviors, you need to differentiate it whether it is a behavioral mouthing behavior or it is an infantile mouthing, which is very, very common. We know that. Or is it an exploratory mouthing? So suppose, a 10-month or a 7-month old child is there. He is doing an explorative mouthing or infantile mouthing. So that cannot be considered to be as a part of this item 9. Whereas a similar child who is a 5-year or a 4-year-old child who is taking everything in mouth, smelling before taking things, that need to be scored on an item 9 in this part. So reactions to pain. So that is why I have mentioned this reaction to pain, because it also comes in response to touch. Suppose just a pencil, just anything, a small stick is being touched on his leg and he screams like anything. It's just a touch. So his response to the reaction is totally unusual. How is that response? Is it too much extreme? Is it normal to that particular situation, or is it very low compared to a peer of the similar age group? So those things need to be taken into consideration. So in this category, there was nothing atypical was noted. That means more or less his reaction to response, pain, touch, and use was absolutely fine. It was normal. Normal in the sense it was majorly it was coming in majority of the reactions is equal to the reaction of this child was equal to majority of the children on similar age group. So fear and nervousness. So item 10 says fear and nervousness means, does he get fear very easily? Does he have unusual fears? Now, unusual fears means, or it may be other way. Does he don't have any fears at all? Suppose he doesn't have any fear of that the dog might bite him. He might be going very close to him. He doesn't have a fear that there is a road crossing, the car might hit him. So he doesn't have that fear. And he might on the contrary, he might get very frightened with the raindrops coming. He might be very frightened with by seeing just a small insect on the floor. He might be very frightened by just seeing a fly on the room. So those things need to be, so you have to take into consideration the positive side as well as the negative side, in the sense whether it can be an extreme behavior or whether it can be an underestimated, or I would say a very low fear, which normally doesn't happen in this child of that particular age. So both extremes of the pole need to be taken while considering the fear or nervousness of the child. So in this category again, there was no atypical behavior was noted, so a score of 1 has been given. So verbal communication. Now in verbal communication, the two most important things need to be taken into consideration is echolalia and use of jargon. Now, when we talk about echolalia, there are two things: immediate echolalia and delayed echolalia. Immediate echolalia means, for example, when you are telling, what is your name? Instead of telling his name, he's telling, what is your name? So he's repeating it. Now, there can be two things. Either the child knows, but he doesn't know how to communicate because there are language issues. The child knows the child has a speech, but it doesn't have a language. So there is a difference between the speech and a language. When we talk about speech, speech means the child has a lot of vocabulary. He utters a lot of things, but it is not related to the context of that particular situation. What you had in breakfast? I'm sleeping. I went to the market. In the market we did. So it is not related to the context what the question is being asked. So the child is having speech but doesn't have the language. So language issues are there, but the speech is there. So when you're talking about echolalia, that thing also need to be taken into consideration, that whether it is actually an echolalia or it is because of the deficits in the language issues. Then there can be a delayed echolalia. For example, he has learned something today and then the next day is repeating. Jack went up to the hill. Jack went up to the hill. He has learned 2 days back, but he's repeating it next day or maybe another next day. So that is called delayed echolalia. Then you have the jargon. Jargon means, we know that jargon speech where the child is making a lot of unusual sounds, but it is not intended to give him some message or anything. And we are not able to, intend to relate any particular message with the child. So it's meaningless words. So those things need to be taken into consideration. If it is a verbal child, also important thing is, How about his tone? How about his loudness? The tonicity, the volume and quality of that particular sounds also need to be taken. Sometimes a child with, those who have ukulele issues, they produce a very typical, notorious type of noises and with frequencies. So those things also need to be look into consideration when we are doing a scoring on verbal communication. So in this verbal communication, the observer observed that he used 2 words to 3 word phrases, which were meaningful, spontaneous comment, labels, and refusal and requests. So that means he was giving phrases of 2 to 3, and they were repeated lines to cartoons or videos, but mixed with the jargon. So he was doing repeated lines. What was Vinas? He was repeatedly doing. So ecolalia was there along with some mixed jargon speech was also there. So immediate ecolalia with some jargon, as I have told you. So there was immediate ecolalia and with some jargon. So a score of 2.5 has been given for this child. So he doesn't fit into the category of 2 score, neither into the category of 3, because 3 says speech may be absent. But in this case, speech was there. Speech may be absent means then he cannot use a word, 2 word or 3 word phrases, which were meaningful. But on the same side, there was some jargon and with immediate ecolalia. So that is why a score of 2.5 has been given, because it neither fits into 3 nor it doesn't fit into 2. When we say speech is absent, they cannot be 2 or 3 word phrases. So one is clear that it cannot be into a criteria of score of 3. So when we come to the non-verbal communication, in non-verbal communication, the most important thing is how about the behavior of the child? Suppose how does he meet his needs? Suppose he wants a chocolate and the chocolate is kept on the shelf one. So he will take his mother's hand and point, or he will raise it. So what we call as hand lending. So those things need to be taken into consideration. How about his behavior? Does he want something? Does he drags the mother hands, or he by himself takes it? So, or if he's not able to take it, how about his reaction? Does he start screaming? Does he start shouting? Probably he might not be able. Some children on the spectrum, they know the bottle is kept, but the mother will be giving water, water bottle to them every 2 hours, because the child cannot communicate verbally and neither he cannot communicate non-verbally. He will not he will not go to the parent's hand. He will not show hand lending, that is raising their hands into and dragging that to meet their desires. So those things need to be taken into consideration when we are doing a scoring on non-verbal communication. So points to things nearby to respond to a question. Occasionally spontaneously points to things at a distance if excited about being something. Note descriptive or emphatic gestures. So there is no facial expression, no facial gestures. Does not look at a person when he is gesturing. So he doesn't look at them. So important, as I've told you, non-verbal communication, verbal gesturing is also important. How about the child respond? Does he respond non-verbally? That is, does he show any gestures? If he wants to, if he wants to go to pee, is he holding his private parts? Does he showing any abnormal things so that can give an indication to the parents, yes, he wants to go? So those things need to be taken into consideration. So he's showing no descriptive or emphatic gestures, does not look at a person when he's gesturing. Suppose mother is telling, I'll give you. So he's not looking at them or he's not observing. He's not able to find what does that mean. So does not seem to understand the gestures of others. So he's not able to read the facial expression of others. So that is why a score of 3 has been given. Okay. So activity level. So when we come to an activity level, we need to take both the poles. That means whether it is too much hyperactive, whether it is too much lethargic. And another thing, when we are taking into consideration the activity level, always take into consideration the effect of medication. Is the child under the effect of any medication, maybe Shizodone, maybe Alprazolam, maybe whatever the medication may be, because probably he might be given for an hyperactivity, and as a result, today he's showing a complete low level of his activity. So those things need to be taken into consideration. It doesn't mean that the child is the mother might have been given, mother might has given him Risperidone or Shizodone in the morning, and now he's totally comfortable, he's sitting, he's just lethargic and sitting at what corner of the sofa, is not moving at all. So that does not give a true level of his activity level, because he's under the effect of medications. So those things need to be taken. So mildly restless during assessment, this is the observation, and did not interfere with the process. So it's a score of 2. That means mildly abnormal activity level was there. The child maybe either might be little restless or somewhat lazy and slow moving at times, but the activity level does not interfere majorly with the performance and other. So that is why a score of 2 has been given. So when we come to the level and consistency of intellectual response, now in this intellectual response, important thing is here we are not judging the IQ of the child. For an IQ assessment, that comes a totally different test that a clinical psychologist or other person need to do a scoring. So here we are not doing an IQ testing. We are not giving a score of the child on the basis of his IQ, whether it is mild, moderate, or severe impaired intellectual impairment. Here we are judging the logical thinking of a child in a particular situation, in a particular environment. For example, a 4-year-old child is being given, okay, uh, this is any example you can give. For example, a 5-year-old child is given. You want to sit with the mother or you want to sit with the uncle? So he will take a decision. Yes, I want to sit with uncle, mama. Or suppose mother is scolding him and papa is not scolding him. Papa is having a chocolate. So we can see his logical thinking. Do you want to sit with papa or do you want to go with mama? So those things need to be taken into consideration, because here we are trying to examine his logical thinking rather than doing an IQ testing. So this is a little confusion whenever we do item 14 scoring. So we need not be well versed with an IQ testing. We need to provide a situations to the child in a particular situation so that we are able to judge his logical thinking in that particular scenario. So does the child have special talent with numbers? So as I've told you, logical thinking and memory. Then how about his response to a particular situation? For example, is he very talented with special numbers or music, for instance? What about his thinking or the tendency to take things literally past for an functional level? Another thing, for example, when you give him a toy, for example, if you want to check his logical thinking, if you are giving him a toy, for example, and you tell him, okay, keep this toy, where you want to keep this toy? You want to keep it on the table or you want to keep it somewhere where it might get fell down? So accordingly, you need to judge the situations. What does the child response in that particular situation? Suppose there is a water which has been kept, or there is something which you have kept on the floor, and do you want to go on, do you want to sit there or you want to sit on the chair? So those things, I mean, I'm just giving you a broad examples where we can judge the intellectual response of the child in a particular situation. Rather than using a word intellectual response, I would say logical thinking of a child. So identifying learning abilities, this is, that's why I have highlighted this. Identifying learning ability disabilities is not the focus of this item score. So discrepancies between the cognitive functioning achievement testing are not intended to be included in this rating. That exactly I'm telling you. I am not here judging his IQ testing or cognitive testing. I am judging his logical thinking here, given in a particular scenario. His IQ might be very, very poor, but yes, he might be doing a logical thinking in a particular scenario, particular situation. See, a question might come, how is it possible that his IQ is lower but his logical thinking is good? See, when we do an IQ testing is done on a set of parameters and a set of skills and on a set of situations and given in a booklet. Then if a child is able to do that, depending upon that, a scoring is done. But here we are giving him the natural environment, we are giving him the natural situations, natural environment, and how he will behave in a particular situation. So that is what here we are judging his logical thinking. So level and consistency of intellectual response in this scale tested. So they have already done the intellectual abilities. Now in this child, IQ scoring was done, which was well below the average. So that is why they have mentioned that tested intellectual abilities and they were well below average. So can name all alphabet letters, read names of favorite characters, count to 25, identify basic shapes, receptive. So they have given a score of 3 in this child. Probably they have given a score on this because already they have done the IQ testing and the IQ testing for this child was below average. Now then comes a general impression. Now this general impression is basically tells you about what all things you have observed in this child in relation to all the 14 items, what all you have observed in this child in this 40 minutes of his observation, and what was your impression after taking detailed evaluation and history and questioning the parents who have come along with the child. So depending upon that, and also the back records, history and everything, and then you will make a general impression of this child in your mind that yes, I will give him a score of either 1, 2, 3, 4. So suppose he has given a score of 3. Now, so what does the score of 3 means? The child shows a number of symptoms of moderate degree of autism. So what are those moderate? So these are the features with the child, this examiner observed in this child. He was having language delays. He was having echolalia. He was having repetitive restricted social interest. He was limited engagement in socially reciprocal activities. He was having repetitive play patterns, resist changes, difficulty with imitation, and plays with toys. So depending upon all these things, the clinician feels that yes, as per my observation, he comes under the category of moderate autism spectrum disorder. For him, it doesn't come under the severe because he was not showing extreme symptoms, although he was showing all the core features of autism, but they were not to that extreme extent. That is why, as per his impression, he has given a score of 3 for this child. So that what exactly means the general impression of item number 15. So this is a scorecard. So when we go a total, so what we do, how we do a total raw score. So these were the various categories: response to people 3. He has given all the scores of this category in this child. So on all these 15 items, a score of 3 to 1.5 and etc was given. And then a total score we calculate that comes out to be 36.5. So this is a total raw score for this child. Now this total raw score for this child is now divided into two categories. That is category of more than age of 12 and less than 12. We'll see in the next slide. And another thing is that this total raw score can be correlated with the percentile. On the right side of the sheet, I have mentioned point number 4. There is a score of 36.5 for this child which came. Now this child was the age of 4 years. So it is in the age category of 2 to 12. So in this 36.5, the T score comes out to be 48 and the percentile comes out to be 42. So what does the T score basically means? T score basically means it gives you an overall impression of the severity of the child in relation to the majority number of children who have been diagnosed with autism spectrum disorder. So that what means the T score. So as the severity of the raw score increases, the T score increases. So we will see the correlation between the T and the raw score in the next slide. So another good thing I was telling you that this CARS2 correlates very well with the functional severity of the autism spectrum. So as per the latest DSM-5 criteria, they have been characterized into 3: ASD level 1, 2, and 3. So requiring support, requiring minimal substantial support, requiring little, and requiring very excess substantial support. So when you do a raw score, so on the above chart, there is a raw score for 0 to 12 and for 13 and above. So our child was in age group of 4 years. I believe Mitchell was 4 years. So 15 to 29.5 for the diagnosis, it comes out to be non-autistic. That means as per the CARS. But as per the descriptive level, it comes out to be likely non-autistic. That means likely. So why they have mentioned likely? Because we are doing a scoring. It is a subjective finding. Probably after a period of 3 months, if we do it, the score might change. So that is why we never write it. He's not showing definitive features. He is not showing no definitive features of autism. We generally don't report in the card. We generally don't report it in the examination sheet because it is a subjective finding. There are no, hardcore criteria that yes, if it is this, it is this. No, it keeps on varying with this, by the level of experience and by the level of how much you are seeing the patient, also depending upon the subjective finding. So we generally mention it as likely non-autistic, so that to be on the safer side, if a child presents at the later after 3 months, we are able to explain to the mother, yes, as we are told, that could be a likely and might increase to a core features of autism. So that is why we always use the words likely non-autistic. So when it comes to a score of 30 to 36.5, it is mild to moderate. So mild to moderate level of behaviors related to autism. That means level 2. When we come to 37 to 60, that means moderate to severe. That means he requires very substantial support to carry out his routine activities. So this is the peculiarity that how these total raw scores are related to the functionality of the autism spectrum disorder. So then you have the interpretation between the CARS and the T score. So a T score of more than 70 means extreme level of autism related symptoms compared to those with autism diagnosis. So suppose you have diagnosed hundreds of autism diagnoses. So this child has the behaviors which are very much extreme compared to those you have diagnosed with autism. So that exactly what it means. So 60 to 70 score means very high level of autism related to compared to those with autism. Similarly, as those the scoring has been given. So in this child, there was a score of 36.5. So a 36.5 with a T score comes out to at a 4 of 43. So 43 means low level of autism related symptoms compared to those with autism diagnosis. So that's what a T score means. But generally, when we report a scoring, we don't give it in the T scores, we give it as a raw score. So these raw scores simply reflect the severity of symptom presentation observed in the evaluated individual in comparison with the clinical sample of individuals with autism related diagnosis. So that exactly what I've told. that it correlates with the number of compared to the maximum number of autism diagnoses that we have done clinically. So thank you. It was a quick and brief description about these cards, and I hope I was able to give some information about this CAR score in this short period of time. Thank you, Dr. Nitin, for inviting me on this very interesting topic for today. Thank you, Dr. Nitin. Over to you, Dr. Nitin.
Dr. Lalit, we haven't received any questions till now, but a request for sharing your PPT is there. So I think if you allow, then we will do that.
Okay, sure. No problem,
Sure.
Dr. Nitin.
If at all there will be questions, I'll be sharing it with you.
Sure, Dr. Nitin. Thank you.
Thank you for all your time, and it was great having you. And there's another question from Dr. Deka where we can purchase cards. So if it is CARS, then maybe from showroom, but on a lighter note, but yes, definitely we'll guide you. So like this, I'll be receiving more questions. I'll get back to you with all of them. Okay.
Sure, Dr. Nitin. Sure.
Thank you.
Thank you.
Thank you for your time. Take care.
Thank you. Thank you very much. Thank you.